welcome to another Piper Pearl. Today's Pearl, we're going to look at the otoscope exam. This is a relatively simple test that you can learn to do in really no time at all. It does take practice to learn what to look for, and there's a lot of different obstacles, if you will, that you'll need to be aware of that you'll find in different patients. So we'll move straight in and we'll just talk about the general consideration of how to conduct this otoscope exam. So when you're doing a patient examination, you can do an otoscope exam for a number of reasons. The main one is obviously to look in the ear when someone complains of ear pain, hearing loss, discomfort, fullness, whatever it is associated with the ear. But it can also form part of the HEENT examination, where someone has a common cold, sinus problem, pharyngitis, and you want to see if there's any involvement with the eustachian tubes or connecting ear problems. Now, when you're starting off to do the otoscope exam, if someone has unilateral pain, it's always a good idea to start with a good ear. It helps establish rapport with the patient, and it also gives us, the clinicians, an indication of what is normal for the human that you're actually treating. Because not all ears are created equal. So always have a look in the good ear, and then you can move to the bad ear as a sort of a comparison. When you're using an otoscope, make sure your tool is fully charged. And the reason for this is not because it's necessarily difficult to see in there, and I'm pretty sure if you didn't have a torch that worked at all, it would be obvious. But if you have a dim torch, the light tends to be more yellow than it does white light. And this can obscure the test and the light reflex of the actual tympanic membrane, and you can get some false negatives. You can even see what looks like cholesterolemia in the background, so the increase of keratinized squamous cells in the back of the ear. It often comes across as a yellow tinge on the tympanic membrane. So always make sure your batteries are nice and bright, and white light is always best. When you're looking into the ear canal, it is always best to pull the pinna in order to straighten the external ear canal itself. Now, there is a condition that affects swimmers mostly, surfers, people that are exposed to cold water, and that's your exostasis. Whilst it's not necessarily dangerous to have exostasis, which is an increase in the bony prominence, or almost like a narrowing of the canal based on a nodule that grows in the ear. It does it as a means to protect the ear after constant exposure to cold water. Now, this can be an obstacle that you'll need to get around, so sometimes you'll need to change your angle of approach in order to accommodate for exostasis. Okay, but straightening the pinna by pulling it up, as indicated in the picture. You read textbooks and it says you've got to pull it up, outwards, and at an angle. But pretty much, as I've mentioned, not all ears are created equal. Always start with an upwards and outwards pull, and then if you need to, gently manipulate the pinna from there. When you're inserting the tip of the otoscope, and if you have a choice of how big the lumen is for the otoscope, especially when you're dealing with pediatrics, always go the largest lumen, so the largest side of the speculum you can, to look into the ear, but be very cautious when you put it in, because cases of osteitis externa can be quite painful. Okay, moving on to some characteristics to look for. Before you get into the ear canal, it's always a good idea to have a look at the surrounding tissue. You can have things like cauliflower ear, which is a chronic condition you can't do anything about. It happens from basically having years and years of getting your head knocked around or getting put in headlocks, that sort of thing. So the cartilaginous areas of the pinna basically get nodules on them. That's all it is. But you can get infections of the actual ear itself and behind the ear in particular. So don't be afraid to have a look at the actual surrounding structures of the ear before looking into the external ear canal itself. Once you get into that ear canal, you can look for excessive wax. Now, wax production was normal, but it's not necessarily needed. So a build-up of wax is not normal. Okay, now it happens due to an increase of the internal cellular structures falling apart and then binding with a sticky substance. Now, people that work in dirty environments are obviously going to be more prone to earwax, but the ear is designed to be a self-cleaning organ, and it uses cilia. So you can technically use mucolytics in order to increase the cilia movement, in order to clear the ears, but sometimes the wax gets too excessive, and if you can't see around it, it's probably the cause for the conductive hearing loss, and you'll need to move on to moving it out. Now, if someone comes in with just hearing loss, then you can obviously go through the process of irrigation using Waxol, olive oil, things like that to remove it, but sometimes they need to be sent away to a specialist in order to have the wax manually removed in order to protect the ear. Apart from wax, you can look at the surrounding structures of the external ear canal, and you're looking for swelling and redness, and they're very, very typical in otitis externa. You can also get lesions and ulcers in certain cases of herpes virus, things like that, and you can sometimes get a discharge. Now, in the case that it's a bacterial otitis externa, then you'll get a creamy discharge. Now, there is a case of fungal otitis externa, which occurs about 10% of the time, and in that case you can see small white buds if it's Candida, or small little black buds if it's Aspergillus. But basically, if it gets bad enough, it looks like wet newspaper that will come out of it. So just have a look for that discharge itself. And of course, everyone's favourite, foreign bodies can in fact be there. It can be the tips of cotton buds. Insects are unfortunately quite common to get found in ears, and also small objects in children. Now, these can be removed much the same way as any other earwax, so you can use irrigation or manual extraction. If the insect is alive in the ear and you want to coach it out, there's tales of using light sources in order for it to come to the light, but what I found works best is you fill the ear with olive oil, place cotton balls over the top, and then basically lie down on the ear, and the bug will want to escape. And your patient will feel it getting to the edge, and then you can just remove it and it disappears. Now, sometimes it doesn't work for flying bugs, but that's often not a bad way to go. Once you finish looking at the external ear canal, you can draw your attention towards the tympanic membrane. Now, the tympanic membrane is obviously a couple of cells thick, and it's used to cover the external ear towards the middle ear, and it's connected to the ossicles themselves. So a good tympanic membrane is a healthy one. You should be able to see the bony structures of the ossicles themselves. As you can see in the picture, you've got the malleus, the incus, and the stapes landmarks that you can look for. Now, the best way to approach a tympanic membrane is to look at all four quadrants. Now, the quadrants pretty much line up down a line of the malleus and then pretty much across the top of the stapes. Now, if you don't quite remember where the four quadrants are, that's fine, but just make sure you look at all areas and surrounding structures in order to prevent missing something. Now, the characteristics of a healthy tympanic membrane is it should be pearly grey in colour and translucent. Now, if you have redness, erythema, it suggests inflammations of the tympanic membrane, and that can occur in otitis externa from infections or inflammatory conditions. When you move to the shape of a tympanic membrane, healthy, it should appear flat. Bulging tympanic membrane suggests an increased middle ear pressure, which is commonly caused by otitis media. Now, retraction, on the other hand, is the tympanic membrane being sucked into itself. Now, that suggests that there's a reduction in middle ear pressure. Now, this can be found commonly when someone has an upper respiratory tract infection or allergies, and that eustachian tube or the pharyngeal tympanic tube is swollen and therefore dysfunction. So you'll get a reduction in middle ear pressure. When you're looking at this and you see it, you can ask the patient to gently conduct the Valsalva maneuver by pinching their nose and blowing out gently. And what can happen is you can watch the tympanic membrane go from a reduction to a flat appearance and see if that actually works. If it doesn't, it means the patient can't actually Valsalva, and the use of decongestants, that sort of thing, can be more helpful to these people. Then we move to looking at the light reflex. The light reflex itself is often known as a conal light, and it's visible when the light is shone on the tympanic membrane. If the tympanic membrane is healthy, the cone-shaped reflex should appear at the anterior inferior quadrant of the ear. Now, if you're in the left ear, the light reflex should appear around the 7 or 8 o'clock mark. And if you're in the right ear, it should appear about the 4 or 5 o'clock, as it does in the picture. Now, the absence or the distortion of this light reflex is associated with otitis media due to the bulging of the TM. So if you can't quite tell that it's bulging, you can look for this light reflex and see if it's a cone, see if it's there, that sort of thing. Now, perforation, nice and easy. Best thing to do is to note the size and the position of the perforation of the TM. Now, the causes of it is obviously infection. It can be trauma, like diving-related trauma, cholesteatoma, which I spoke about before, which is the increase of squamous cells. And of course, you can have an insertion of a grommet as well, which can cause a hole to be formed. Now, this cholesteatoma typically causes a perforation in the superior part of the tympanic membrane, and you may actually see granulating tissue and discharge within that region itself. And the last thing to look for is your scarring. Now, scarring often occurs because someone's had perforation in the past or they've had a series of grommets inserted. So that's typically what we look for when we're looking into the ear. Now we'll just go through a few pictures just to denote a few telltale signs that we can find before finishing up. So the picture on your left, as noted, this is a normal tympanic membrane. Its color is grey. It's translucent itself, so you can see through it. You can see the actual ossicles themselves. Not as clear as the other picture, but you can get a glimpse of them. It's flat. It has a light reflex. Okay, so this one here is obviously the left ear. And there's no scarring and there's no perforation itself. When you move over to tympanic rupture, this one's nice and easy. Hopefully everyone can see the rupture that occurs in there. So from there, you pretty much lose ability to look for anything else, and that's enough. You see a rupture, you see a hole in tympanic membrane, and that can be your diagnosis, and you can go from there. Now, when you're talking about otitis media, there are many different forms of otitis media, but the main characteristics that you look for is you have the redness. Okay, so it's no longer grey in colour. It is no longer flat as well. It often has that bulging effect once it starts getting up to the fluid increase, and it loses its light reflex. So even though there's a spectrum of otitis media that you can look for, a lot of different causes as well, the characteristics are often the same. And then from there you need to distinguish whether or not it is bacteria related to treat with antibiotics. But most of the time the use of nasal decongestants can be very helpful for people with otitis media. Regardless of the cause, after the case of otitis media or otitis media with effusion has passed, the patient needs to come back for a hearing test. Okay, so that ends the lesson on otoscope examination. Like I said, quite an easy technique to do, but does take quite a long time to master. I've given the overall characteristics of what to look for. Best thing you can do from here is look in 100 ears, 1,000 ears, learn the difference, go to areas where there's surfers, go to areas where you'll find divers in order to see the different characteristics of people's ears, and always look out for things that are not otitis media. But until next time, take care.